Kia ora everybody, welcome to our Hospice West Auckland Palliative Care webinar. Today is the first one for 2025 and we are happy to have Dr. Imran Gopaul presenting on depression in the palliative patient. Please join me for a karakia to set the intention for the session. Tuia ki runga, tuia ki raro, tuia ki waho, tuia ki roto. Tuia te here tangata, ka runga te pō, ka rongo te ao, hongia, huia, taiki. Later in the session, Dr. Imran will be joined by a panel of palliative care experts. The Q&A will be led by Dr. Oleg Kiriaev, and panelists include Amy McDonald, Katie Kim, and Charlie George, who are part of our Hospice West Auckland clinical team. Throughout the webinar presentation, we would invite you to add your questions using the Q&A function. I would like to hand over to Dr. Imran Gopaul. Enjoy the webinar.
Hello everyone, my name is Imran. I'm a palliative care doctor working at Hospice West Auckland. I would like to thank you all for taking the time to attend this webinar. I trained in general practice and I was attracted to palliative care due to the holistic model of care, which makes it quite special. I believe that treating the whole individual, including the psychosocial, emotional, and spiritual impact of the illness, is what makes the difference in our line of work. The reason I chose this topic is that in spite of our attempt to provide this holistic care, depression in the palliative patient is often overseen. I will therefore start by exposing the problem, followed by the consequences of untreated depression, and followed by some recommendation and about how to tackle the issue. So there is a common misconception that depression is a universal and normal phenomenon in seriously ill patient. So most people think that all the patients facing or contemplating end of life are depressed. There's a lack of knowledge and skill at recognizing and treating major depression. And a lot of the time, the busy medical staff may not recognize depression, and the severity and impact of this disease is underestimated. So depression in palliative patients pose a diagnostic challenge, as somatic symptoms such as loss of appetite, fatigue, sleep disturbances, and reduced concentration are less specific in cancer patients. And there's a fear of upsetting the family and patient at an emotionally vulnerable time. So the questions pertaining to mental health are personal, and there's a fear of upsetting them. The dose of a prescribed medication is often inadequate, and more often subtherapeutic doses are prescribed. There's a fear of interactions with a multitude of medications taken by the palliative patients. We will go into the medications a bit later in the webinar. And some clinicians may feel a sense of hopelessness that can lead to therapeutic nihilism. So nihilism is a belief that any intervention would be meaningless, which we often see with other healthcare professionals dealing with palliative patients, unfortunately. So in a survey of 1,046 hospice patients in the UK, only 10% were prescribed antidepressants. That's from a survey in 1999. The same survey showed that patients prescribed tricyclic antidepressants were nearly always underdosed, and 75% of those started on antidepressant died within 2 weeks. There was another cross-sectional analysis in 2014 that showed that patients with cancer and depression in Scotland, 70% were not receiving potentially effective therapy. It implies that there was consequently insufficient time for the medication to have a therapeutic effect, especially as there were no prescriptions for any psychostimulants, which are the ones that are quick acting. The 2008 Institute of Medicine report states that the psychological needs of the patients with cancer are not being addressed, and this is posing a serious problem for the US healthcare. And I think it will be the same in New Zealand and in the whole world. So the consequences of untreated depression. So there's worsening of symptoms. So there's maladaptive coping, which amplifies pain and other symptoms. Depression lessens the ability to tolerate the stress of physical symptoms. There's somatization, which complicates optimal palliation. Decision-making is influenced, and in a lot of situations, the patient will be asked to make quite some important decisions regarding their treatment, especially when they're having some treatment that can change the course of the disease. There's existential distress, and existential distress in our patients, as you may know, is one of the biggest challenges faced by the palliative care teams. More so that it also pushes us to face our own existential distress at that time. There's a higher mortality, like a 39% increase, independent of other risk factors in patients with untreated depression, which is possibly related to neuroendocrine changes linked to increased stress levels. There's also diminished quality of life, family dynamics, difficulty to be cared at home, and need for increased institutionalization, or no, I'm going to get that right. Increased risk of suicide, increased requests for assisted dying, physician-assisted suicide, and also the economic consequences for providers and the healthcare system. The depression causes, in the palliative patients, causes additional anguish and worry in family members and friends who are often the carers for the patient. So the consequences of untreated depression, it impairs the patient capacity for pleasure, meaning, connection, and doing the emotional work of separating with their loved ones and saying goodbye. So this is the first one of our poll questions where you are all asked to answer, and then we'll discuss it. So what is the estimated prevalence of depression in palliative patients? Right, so we've got most people think about 24 to 70%, and then 11 to 24. So that's actually right, as shown by the next slide. For some reason, it's not changing. Right. So the prevalence of depression in New Zealand in general population is about 17%. And the prevalence of depression in the palliative care patient is about 24 to 70%, which most people chose. So this wide variability is explained by the lack of agreement as to appropriate diagnostic criteria for depression used in the setting of advanced illness. differences in patient population, and the variation in the assessment methods. And the prevalence at the end of life is around 50%. So psychiatric disorders are more prevalent among patients with cancer than among those with any other chronic illnesses. So with CKD, we've got about 27%, with Parkinson, 20 to 40%, MS, 35%, heart failure, 22 to 46%, and HIV/AIDS, 23 to 52%. So what is grief? So as Freud observed, grief is the reaction to the loss of a loved person or to the loss of some abstraction which has taken the place of one, such as one's liberty. Grief manifests as a progression of emotional, social, spiritual, physical, cognitive, and behavioral changes through which a person attempts to reorganize and resolve or adjust to the loss at his or her own pace. I thought that was quite a good definition of grief. So grief is a normal response to loss. So almost all persons experience grief when faced with serious illness. So it's often manifested as physical symptoms, insomnia, loss of appetite, and emotional, social, spiritual, cognitive, and behavioral changes. So the symptoms of grief could be like disbelief, shock, numbness, feeling of unreality, anger, feelings of guilt, sadness, and tearfulness, disturbed sleep, appetite, and weight loss. So the adaptive process in attempt to resolve or adjust to the losses imposed by the serious illness, and it usually responds well to counseling. As opposed to complex grief, which is a very intense reaction, the symptoms are outside the normal range which are usually seen, and there's preoccupations with feeling of worthlessness, thoughts of death, excessive guilt, marked slowing of thoughts, prolonged period of not being able to function normally. And it may require pharmacotherapy and also psychotherapy and counseling. So complex grief affects 7% of patients and is characterized by more severe symptoms that, as I said, may require pharmacotherapy. So various theories have been used to describe the grieving process. Elizabeth Kubler-Ross proposed the 5 stages of normal grief in 1969 in her book On Death and Dying, which I think you're all familiar to. More recently, there's been the dual model of coping illustrates the positive and negative cognitions with consequent regulation of emotions is a more important and realistic process. In this model, the grief-affected person oscillates frequently between confrontation, which is the restoration-orientated, and avoidance, which is the loss-orientated. Ideally, the person becomes more restoration-orientated over time, reducing the time spent on rumination. So back to depression. So depression is persistent dysphoria, anhedonia, sense of hopelessness, helplessness, worthlessness, active and persistent desire for an early death. So other presentations can be that of patients complaining of pain everywhere and like feeling sad all the time. Many individuals, about 50 to 60% with a diagnosed depressive disorder, will also have a comorbid anxiety disorder. So the assessment should identify signs and symptoms of anxiety, which are like panic attacks, trembling, sweating, tachypnea, tachycardia, palpitations, and sweaty palms. For that, the patients can be assessed using a screening tool such as the GAD-7, but we won't go through anxiety in this presentation. This slide just shows some mnemonics, which is commonly used to remember the DSM-5 criteria for depression. Now, the risk factors. The Canadian Network for Mood and Anxiety Treatments, clinical guidelines for management of adults with major depressive disorder. The risk factors usually are classified as clinical or symptom related, ranging from the history of depression, the family history, psychosocial adversity, high users of the medical system, chronic medical condition, other psychiatric conditions, and times of hormonal challenge. Symptom factors, unexplained physical symptoms, chronic pain, which is one of the things that a lot of our patients have to endure, fatigue, insomnia, anxiety, and substance abuse. Other risk factors, according to the WHO, are classified as either biological, psychological, socioeconomic, and cultural factors. Now, those are all the risk factors for depression in the general population. We'll move on to the cancer-related risk factors for depression. So, younger cancer patients tend to have higher rates of depressive disorders, prior history of depression, uncontrolled symptoms, as I mentioned before, particularly chronic pain, degree of physical impairment or discomfort, and head and neck cancers and pancreatic cancers, primary or metastatic brain cancers. So for patients with pancreatic cancer, psychiatric symptoms may sometimes precede physical symptoms by several months. Certain treatments can actually increase the risk of depression, and such as with chemotherapy, brain irradiation, and medication. Those medications include benzodiazepines, corticosteroids, anticonvulsants, methyldopa, and propranolol, and spiritual suffering. So to note that patients with high levels of spiritual well-being tend to be less depressed. So existential suffering and deep personal anguish are some of the most distressing experiences that occur in the dying. That's from Boston in 2011. We're moving next to our second poll question, which is depression more common in the female cancer patients? So the answers, we got a 52% of yes and 48% of no. So depression is more common in females, but oops. So while depression is twice as common in women than men in general, gender is not consistently reported to be a risk factor for depression in cancer patients. So we'll move on to the overlap between depression and grief. So while emotional distress is natural and expected in patients experiencing serious illness, the differentiation between a normal appropriate reaction and a more serious psychiatric disorder such as depression can be clinically challenging. Depression and grief are different clinical conditions that require different treatments. Although clinically they often overlap, misdiagnosis can result in overlooking depression when it is present or inappropriately treating grief. So the next slide shows an algorithm above which shows the overlap of processes at the end of life. The symptoms are shown in the blue box lack specificity, which makes it difficult to differentiate between grief and depression at times. So to help us differentiate from the two, one can use the Palliative Grief Depression Scale, which is a self-reporting measure designed to differentiate between preparatory grief and depression. It has been validated in a small series of 47 adult inpatients. This is what the form looks like. So you've seen the columns. D stands for depression, ROG stands for restoration-oriented grief, and LOG stands for loss-oriented grief. So the patients will score points, and then from different calculations, the scores are done at the end, and it will give you the probability of the patient having depression or just experiencing grief. So the bottom line is, so what is it? Grief or depression? A person should not be denied effective treatment on the basis of understandability, nor should arbitrary timeframes as per definitions in the DSM-5 or ICD-10 become more important than assessment of clinical need. So dysfunction is key for the need to treat. We'll move on to our next poll question, which is what is the estimated prevalence of patients with depression who request physician-assisted dying? All right, we got some answers here. We got 26% have chosen 10 to 20, 30% 21 to 40, 28% 41 to 60, 9% 61 to 80, and 7% 80 to 100. So the answer is usually around the 60% mark. The depression is often underdiagnosed and undertreated in palliative care. So the depressive symptoms are common in palliative care, yet they are widely misunderstood, underdiagnosed, and undertreated. Two-thirds of palliative care physicians are not confident in diagnosing depression, and the barriers are lack of rapid efficacy, frailty, intolerance of assessment, complexity of differentiating depressive symptoms from other issues. So what are the barriers to effectively manage depression in palliative patients? So the treatment for a patient with a prognosis of years is different from the patient with a short prognosis. There's a fear of administering ineffective agents. There's some apprehensions about drug-drug interactions. General studies on depressions are not generalizable to the palliative population, so there's limited research. And 47% of palliative care physicians had difficulty assessing psychiatric input. So the American Society of Clinical Oncology recommendations for screening, assessment, and care of anxiety and depressive symptoms in adults with cancer. The guidelines was adapted from a pan-Canadian practice guidelines on screening, assessment, and care of psychosocial distress in the adult with cancer. So point one says that all patients with cancer should be evaluated for symptoms of depression and anxiety at periodic times across the trajectory of care. So the reviews with changes in the disease status, such as post-treatment, recurrence of a disease, or progression of a disease, or when there is a transition to the palliative and end of life stage. So there is the need to use culturally sensitive assessments and treatment to tailor assessment and treatment for those with learning disabilities or cognitive impairment. And there's also the difficulty in detecting depression in the older adult. So assessment should be the shared responsibility of the whole clinical team. So to facilitate that, we've got like screening tools. So characteristics of screening tools that can help with diagnosis and guide management. So ideally, the screening tool should be easy to use, and it should allow self-rating so the person can do it even not in the presence of the clinicians, can be completed by the family member. One which is validated in palliative patients and acceptable to patients. The downsides are most do not differentiate between grief and depression, so there'll be a high rate of false positives. Many of the existing tools are unsuitable for seriously ill patients, and it is important to remember that the gold standard method of assessment is a careful diagnostic interview. We commonly use depression screening tools. There's the single item, which is the SADS, which is a schedule for affective disorders and schizophrenia, with a sensitivity of 47% and specificity of 93%. So this is asking the patient the simple question, have you been depressed most of the time for the past 2 weeks? However, the meaning of being depressed is different for different people and cultures. And while some patients may readily verbalize that they are depressed, others, no matter how despairing, may never acknowledge it or may label it as something else, like such as nervousness. There's the second one, which is using the two items, which is the PHQ-2, which is little interest or pleasure in doing things, which is anhedonia, and feeling down, depressed, or helpless. And the PH29, which is mostly used in general practice in New Zealand and integrated in systems such as the MedTech 32 and the hospital anxiety depression scale, where the physical symptoms are not included. Other screening tools are the SEDS, EPDS, the Kessler, and the visual analog scale for depressed mood. Of note, the CSD is relatively unaffected by the presence of physical symptoms. So we'll move on to the treatment of depression. So if at risk of harm of self or others, so it needs to be referred for emergency evaluation. We need to facilitate a safe environment and one-to-one observation and initiate appropriate harm reduction intervention. Severe depression or agitation in the presence of psychosis or confusion require immediate referral to a psychiatrist or physician or the CAT team. So it is common for a patient with depression not to follow through on referrals and to comply with a treatment recommendation. So with a treatment of depression, it's important to assess follow-through and compliance with referrals, as well as satisfaction with these services. So we need to be able to offer supportive care services for all patients as available and appropriate, like offering support, providing education and information about depression and its management to the patient and families. Next slides, we're going to discuss between the pharmacological and non-pharmacological management. So with pharmacological management, so patient with severe depressive symptoms may be too immobilized or dysphoric to effectively engage in psychotherapy initially. Such patients may need to receive appropriate pharmacotherapy first. So the pharmacological therapy, general principles. So first, pick the antidepressant that you feel comfortable with. Prescribing and know these drugs well. Those with less interaction, such as sertraline, citalopram, and the availability of a liquid formulation, as more often in the palliative patients, like when at the end people start to lose the ability to swallow medication. Paroxetine and sertraline are likely to be better tolerated SSRIs because of fewer active metabolites, which can accumulate and cause toxicity. Citalopram and escitalopram has significant fewer interactions with hepatic metabolizing enzymes such as other SSRIs. So point 2, consider their side effects and additional therapeutic benefit. So the side effects such as SSRIs and SNRI with GI bleeding, citalopram such as hyponatremia, bupropion such as seizures, which is important in patients with brain tumors or cerebral mets. Mirtazapine can cause agranulocytosis, although rare. The therapeutic benefits are also of use, such as neuropathic pain with tricyclic antidepressants and mirtazapine, which we often use to aid sleep, appetite, and nausea. So start at a lower dose and increase slowly and review fortnightly. So starting doses would typically be a bit lower than we use in the general population, such as sertraline 25 milligrams, citalopram 5 milligrams, venlafaxine 37.5, and mirtazapine 7.5 milligrams. So as I said, avoid tricyclic antidepressants as first line, fluoxetine or paroxetine. And for patients with a shorter prognosis, consider a psychostimulant due to the fast onset of action. So the use of outcome measures should be used routine, minimally pre and post treatments to gauge the efficacy of treatment for the individual patients and to also monitor treatment adherence. So moving on to non-pharmacological interventions. So as you can see, there's a lot of non-pharmacological interventions available out there. Supportive therapy aimed to support adaptive coping mechanism, minimize maladaptive ones, and decrease psychological reactions such as fear, shame, self-loathing, and withdrawal. Clinicians should explore the patient's concern about death and the dying process, and supportive therapy can be provided by the primary medical caregiver, psychologist, hospice nurse, or social worker. So we'll move on quickly to this paper, which is a systematic review about the evidence-based management of depression in palliative patients. This is a paper from 2021. So the summary of clinical efficacy of pharmacological interventions, those with overall significant benefits were methylphenidate with mirtazapine, fluoxetine, desipramine, and ketamine. So of note, desipramine and nortriptyline are less cholinergic than amitriptyline, and there's less risk of developing anticholinergic delirium. So beneficial and not significant was methylphenidate in addition to SSRIs, and no significant benefit was mazindol. Now we'll go quickly between with those medications. Mirtazapine is one that we use quite frequently, and the doses, as I said, would start with 7.5 and gradually go up to 30 milligrams. It will help with increased appetite. It has anti-nausea properties, help with weight gain. At smaller doses, it will also help with sedation. So we give it mostly at night, and overall improves quality of life. Psychostimulants such as methylphenidate have a faster onset of action, which is useful in those with a short life expectancy, which is such as less than 2 months, and those in need of urgent treatment. They can also stimulate appetite, promote a sense of well-being, and relieve feelings of weakness or fatigue. So oral ketamine has been used quite more often recently. The oral dose is 0.5 milligrams per kilo. So it's a much lower dose than what we use for pain. The anxiolytic effect is evident by day 3 and the antidepressant effect by day 14. The effects are, it's effective, but benefits are not long-lasting, but there's a rapid onset. So the side effects includes disorientations, hallucinations, sedation, insomnia, and delusions. So it's not recommended for your patient who is at risk of developing delirium. We'll move on to the summary of clinical efficacy of a non-pharmacological intervention. So those with significant benefit are the cognitive behavioral therapy, cognitive therapy, counseling, clinical hypnosis, acupuncture, dignity therapy, music intervention, mindful breathing, short-term life review psychotherapy, guided imagery, and progressive muscle relaxation. Those which are beneficial but not significant, such as focused narrative intervention, short-term psychosocial intervention, and aromatherapy. And a list of those here that are but didn't show any significant benefits. So being a dog lover myself, I don't think we've given enough credit to dog petting as we should in this study. So in conclusion, methylphenidate elicited an earlier induction in remission compared with mirtazapine alone. Methylphenidate also provided a benefit in alleviating fatigue. The combination therapy resulted in faster induction of remission and decrease in relapse rates. Cognitive therapy was the only one with the evidence of long-term benefit over 6 months. And yeah. So quickly about psychedelics before we finish. So psychedelics, there's been a lot of it in the press recently, can be classified based on their pharmacological profiles. So your classic ones such as LSD and psilocybin. And then you've got your empathogens and enactogens such as MDMA, your dissociative anesthetic agents such as ketamine, and your atypical, which you will see there's THC is one of them. So it's been extensively used in the treatment of mood disorders and other psychiatric conditions before their prohibitions in the late 60s. It's been linked to long-term improvement in depression. There's the question of a single dosing versus the psychedelic-assisted psychotherapy. It improves spiritual and existential well-being, and it decreases death anxiety. So a clinical study using mushrooms containing the psychoactive substance psilocybin to treat methamphetamine addiction has just been completed its first phase of trials in New Zealand. And in Australia, psilocybin can be prescribed by an authorized psychiatrist to people experiencing treatment-resistant depressions, and that has been since July 2023. I'm just going to introduce my panel, which is Dr. Oleg Kiriaev, palliative medicine specialist, Katie Kim, clinical pharmacist, Amy McDonald, palliative care counselor, and Charlie George, clinical nurse specialist, to go through the round of questions. Thank you.
Lovely. Thank you, Imran. Thank you for giving us such a thoughtful and detailed account of all the issues we experienced when we are confronted with depression in our patients. So we've got a number of questions to go through. So the first one, how are you defining the difference between depression and anticipatory grief? I think you already went through that in some detail, Imran, but are you able to just highlight the key points or factor you use to discriminate between those two?
So I think the main thing is the degree of dysfunction which is affecting the patient. So there will be a level of normality where the patient is actually dealing with, the news, the fact that they're losing their independence, they are now having their lives like being reduced and stuff. So there'll be all these factors, but then there are also the others where there's issues with worthlessness, guilt, and rumination, and that's where we see things going into a pathological way. And as I said before, and it's the degree of dysfunction and inability to actually cope with the grief that actually will make us think about the patient heading towards the depressive path.
Mm, yes, great. Thank you. So the next question, I'm just wondering how you guys treat depression. I know medicines are one of the ways, but in what other areas of care do you provide care in a holistic way, i.e. incorporating Te Whare Tapawha? Amy, what are your thoughts about that?
Yeah, hi, thanks, Oleg. Well, our social care team, we offer a range of services that treat the whole person holistically. For example, we have a rongoa practitioner, a spiritual advisor, a massage therapist, and then we've got art therapists, music therapists, and us counsellors as well. So, and we're often talking about, and debriefing and talking about approaches and what works best.
Mm. And where do you see patients, Amy, or where does your team see patients?
Yeah, so we can see patients at home if that's more suitable for them, if their condition means that they find it difficult to come into clinic, or at hospice at the clinic. We also run groups as well, and we run those for patients, so that can really benefit them with that connection and belonging, and help normalize adjustment and processing of experiences and their emotions as they adjust.
In whānau as well, I'd imagine.
That's right, they come along as well. So we can do couples therapy and whānau hui. So whatever's required, really, we can provide.
Yes,
awesome.
I think it's very important to involve the family, because we only see the patients for a short amount of time, and the patient is with the family for the rest of the time. And it's very important if the family is on board and understanding what's happening to the patient, sometimes the difference in the patient's behavior, and they're able to support that patient and actually continue with the management at home.
Absolutely. It's not uncommon to see carers and whānau. We do one-to-one with them as well if that's required. Yeah.
Great. Thank you. Moving on, what's a monitoring action plan used by a depressed patient? Are they signs, i.e. lab results, or do you use monitoring, or do you use these plans to monitor progress, or is it all subject to patient comments? Bit of a curly one. Do you have any thoughts about that, Charlie?
Thanks, Oleg. I guess it would be repeating the assessment tool that we would have used to identify that patient has depression. So for me, I quite like using the Kessler psychological distress scale. So initially, when I assess someone or routine assessment, I would start with an IPOS, and that would give me a bit of an insight into whether they feel they do have depression. But I guess, like Imran has said, depression means different things to different people, and some people don't acknowledge that they have that just by asking if they are depressed. So if I feel there is some concern there, I would move on to doing the Kessler, which is a 10-question scale about emotional states with a sort of 5-level response scale, which can just give us a brief sort of screening to identify that level of distress or depression. Then if someone's being started on therapy, pharmacological or non-pharmacological, I guess we would repeat those scales on a routine basis. with antidepressants, I think it's really important, or medication, to make sure patients are aware that that will take some time. And I think that can be quite a challenge for people. They want to sort of have an immediate response to things, and it's really ensuring that they know it can take at least 2 weeks for us to start to see some response, and then whether we need to increase that dose or not. I think for me, having a caseload of patients that we get to know is quite helpful, because you can see those changes in people. But there wouldn't be any sort of lab tests that we would do for people. It would be more a response on those scales, and seeing a change in someone.
So that close follow-up
Yeah, for
on a
sure.
regular basis
And
and
I think
tracking them.
and I think involving family and whānau as well, they can often be the ones who see those sort of slight changes in people. And if they are involved with other team members, such as Amy and the rest of her team, sort of getting their feedback as well is useful.
Yeah, thank you. Thank you, Charlie. So is it okay to give methylphenidate if patient is in palliative care with heart disease like failure, cardiomyopathy, etc.? Katie, you probably are best to answer that question.
Yes, so methylphenidate has stimulating effects, so it can cause tachycardia, high blood pressure. And so in patients who have heart disease, like failure or cardiomyopathy, it may worsen or trigger the symptoms of arrhythmias. So it's not a do not use, but I guess it's to be used with caution if the benefits outweigh the risks. And I would recommend to start on a low dose and monitor closely, and also monitor the blood pressure and the condition. Anything to add, Dr. Imran?
I think you're right. I think we're looking at quality of life for the patient and just starting on a small dose. And if that's working for the patient, but making sure that we know what are the downsides of it. But I think in palliative patients, we often use a lot of medications off-label and those with relative contraindications. But it's just because there's we want to increase their quality of life, even if it's for a shorter term. And I think it's something that we discuss with the patients, and they usually opt for that.
I guess the other thing to add with regard to methylphenidate, I don't use it very often myself, but on occasion that I do use it, you do notice a therapeutic effect pretty much immediately if you are targeting specifically depressive symptoms. So literally within a few days, you know whether it's going to work or whether it's actually going to just cause more harm than good. So that's the great thing about it. The tricky thing with methylphenidate is that it's not freely available or easily accessible, Katie, in terms of subsidies. What's the criteria? Can you just remind us all?
Yes, so a palliative care physician can prescribe methylphenidate for palliative care treatment, and then the GP can do follow-up prescriptions after that, but there's no special authority available for palliative use. It's only available for ADHD and narcolepsy. But in saying that, the treatment isn't particularly expensive. There had been some stock issues in the past, but that's resolved as well. So it is quite accessible as an option if it's clinically appropriate.
And if it's simply for a very short period of time as an initial trial as well. Great. So moving on, what does Hospice West Auckland offer in terms of counselling and bereavement services? I think you've already talked a lot about this, Amy, but can you just remind us?
Yeah, sure. So we've got a bereavement group that we run. We have a patient social group called the Coffee Group. Pet therapy comes into that. You'd like that, Imran? And we do also one-to-one counselling, and we've got quite a community happening at Hospice where people come in and do exercise classes and Tai Chi, and enjoy a cuppa. So yeah.
Absolutely great. And I think also we do have the volunteer service, and they can be quite supportive, especially if transportation or those sorts of issues become a barrier for access.
That's right. And we definitely go into the homes of patients as well. Yeah.
Yeah, yeah, good. All right. Well, that in actual fact are all the open questions that I'm aware of. Does anybody have any other final thoughts or comments in the panel?
I had a little thought.
Yes.
It was just in relation to Imran, when you said that chronic conditions are a risk for depression. And I think we're seeing more and more now that cancer treatment sort of leads people into like a chronic sort of illness space. You know, people are living longer with cancers. We've got these novel treatments and therapies. And so I think that can be a risk factor for people because they've been on this long journey of treatment and then that stops. And I think we perhaps underestimate the effect that has on someone's sort of psychological state. And so I think that was a very interesting point, that long-term conditions can increase your risk, and probably cancers, you know, certainly things like breast cancers and prostate cancers we're seeing now are more long-term.
Yeah, and as we know with like depression, I mean, with these chronic conditions, they actually change your life. So some people are not able to exercise. Some people, let's say they have like a colostomy bag, they don't want to socialize anymore. So there's all these changes that sometimes can lead people into actually getting a higher risk of getting depression. So there's these significant changes that can happen because of a disease, although we don't see the patient as sick, but the change in their life, their condition predisposes them to that.
Yeah, absolutely. I remember when I was going through training, when I was a registrar, it might be a bit contentious to say now, but you know, there was the recognized rheumatoid personality. So people with rheumatoid arthritis and chronic pain for years and years and years and decades can become quite despondent, can be, you know, their quality of life is so impacted by their disease that inevitably there's that association with depression and despondency. So that was very well recognized, you know, decades ago even. So, and that just makes intuitive sense, doesn't it? We've got a couple more questions that have just popped up. Any support/resources for family, especially young children with parents going through palliative care? Thanks. Who'd like to answer that one?
If you look on our website, we have resources there that can that you can either look at and use or point you in the right direction. Yeah.
Awesome. Yeah. Or simply just give us a call.
That's right.
And we'll touch upon that in a second. But we have time for one more. This is more of a comment as well as a question. And it says, I love Charlie's comment about getting to know the patient over time and including whānau makes sense. Alan Kelleher estimates people only spend 5% of their last year of life with a health professional. In my role as a doula, I often find that having time to spend with a person and having deep and meaningful conversations helps to lift the burden of fear by discussing what death usually looks like and exploring what they think happens after you die. Also help with anticipatory grief, which is huge, and maybe avoid depression. Yeah, well, that's a very interesting and insightful perspective. Absolutely, I completely agree with that.
Yeah, and I think it probably helps people open up a bit more if you are with a health professional that I guess you trust and get to know, and then maybe that sort of leads into sort of the diagnosis of depression because they feel like they can discuss those things with you. So yeah, I agree, Teresa.
Maybe time for one more question. This is also potentially up your alley as well, Charlie. In terms of home visits, out of curiosity, is there a protocol in place to ensure staff are safe?
Absolutely, because we from a nursing point of view, most of my work is in homes or where people call homes. That's not always sort of just private residences. So we rely quite a lot on the information we get with referrals, but that is triaged and assessed on the phone before we go out. And if there's any identified risk, then we will go out in pairs. Yeah, so safety is our priority, and we do have a lone worker device as well with us at all times.
Yes, that's right. And a quick follow-up on the extra resources. That's, I think, Amy, you just said on our internet websites.
That's right.
We've got extra resources there. Great. But if you are wanting to talk with us about a patient you're caring for or involved in, Waveney, I'll get you to put up the Dr. Direct line. So by all means, give us a call. The Dr. Direct line is manned during working hours, and that comes through to either myself, Celia, or Imran, or else after hours, or any time, day or night, or over the weekend. We do have an 0800 number that you can call, which goes directly through to our coordinator. And that brings us to a conclusion for this morning's webinar. I'd like to thank Imran and all the panelists, and a huge big thank you to Waveney for organising it all. And I'll hand the session back to Waveney to close.
Great, thank you, Dr. Oleg. And thank you for leading us through that discussion, and to Amy, Charlie and Katie for your expertise. We really appreciate you being part of the webinar today. Lastly, thank you, Dr. Imran, for your insightful session. We do really value your passion for providing high quality education around palliative care. Please remember to fill out the reflection form at the end of this webinar. And I'd like to just close with the English version of our karakia. Unite above, unite below, unite without, unite within. United as one, listen to the night, listen to the world of light. Now we can come together as one.